Hello, and welcome to our professional series. I am Cynthia Milburn from Epilepsy South Central Ontario. And today we are so very privileged to have Dr. Taufik Valiante giving us important information on surgical options for epilepsy patients. Dr. Valiante completed his residency in Neurosurgery Training Program at University of Toronto in 2002 and an Epilepsy Surgery Fellowship at the University of Washington, Seattle, under the mentorship of Dr. George Ojemann in 2003. In 2007, he established a state-of-the-art 5-bed epilepsy monitoring unit at the Toronto Western Hospital, significantly increasing surgical services to those with medically refractory epilepsy throughout the province of Ontario. Through his involvement with professional and not-for-profit epilepsy organizations such as ours, he is a strident advocate for standardization of epilepsy care. His CIHR-funded research focused on in vivo and in vitro electrophysiology recordings of brain activity. His particular interest in the association of such activity with cognitive processes and the cellular mechanisms that underlie them. He studies the pathological disruption of such activity using optogenetics and computational techniques. He is currently the director of the Surgical Epilepsy Program at the Krembil Neuroscience Center, a scientist at the Krembil Research Institute, and has cross-appointment at the Institute of Biomaterials and Biomedical Engineering. His neurosurgical staff appointment is at Toronto Western Hospital, and he is currently the Associate Professor of Neurology at the University of Toronto. I would like to also comment that Dr. Valiante is so very approachable and he is so endeared by his patients. And I have two testimonials here just to start off. There's one patient that said Dr. Valiante is an amazing neurosurgeon. He's done 3 of my 4 surgeries. And another woman, he is amazing. Almost 11 years ago, he removed a small piece of the brain where my seizures were stemming from. I was in my early 50s, seizure-free ever since. He gave me my life back. I'm so very pleased to have Dr. Valiante speak for us today.
Yeah, good morning, everybody. Thanks, Cynthia. It's always a treat. I think I grew up professionally initially in the community, and so I just love the opportunities to sort of be part of it at every chance I can get. So I'm very happy to be here. So I have a little bit of a talk, and then hopefully we'll get into the most important part, which is really the questions that everybody has. So I'm just going to go ahead and share my screen here. And I hope everything is looking okay. This is my first slide. So yeah, I'm going to talk a little bit about epilepsy surgery and kind of some of the things that we're offering and new things that we're offering in our program. As you know, the only constant is change. And so we're very motivated to provide the latest surgical approaches and technologies to individuals who unfortunately have epilepsy. Before I get into that, however, you know, we can't not talk about coronavirus. And as you probably have heard, now it's even if you go shopping, they really encourage you to wear a mask. And these are 2 students of mine, Kreme and Chaim, who actually have started Stitch for Corona. They've distributed, I think, over 4,000 masks. So if you don't have your own or your organization doesn't have any, you know, contact these guys, and the links are there, and I can certainly provide them afterwards. For those people who are not initiated in the context of epilepsy, just a brief overview. So really one can think of epilepsy as a storm in the brain. Each seizure is accompanied by too much electrical activity. According to the World Health Organization, it's the most common serious neurological disorder in the world, with about 1% of the entire world and 0.6% in developed countries. This leads to not an insignificant number of people having epilepsy. Now, not a small fraction of almost 70% of people will be relatively well controlled on medication, leaving the other 30% of individuals who are not well controlled and medically refractory. About half of those can undergo surgery, and that's kind of what we're going to talk about today. The last point I want to make is that until we got involved and until there was sort of a concerted effort in the province of Ontario, only about 2% of people actually had access to surgery. A lot of efforts province-wide with all the neurologists, neurosurgeons, all the allied health. We were able to actually standardize care through the province of Ontario, and this is a very important thing for people to know about because we really are the only place in the world that has a regionalized approach to epilepsy. And this has really improved our ability to standardize care through the province, garner resources, both from a clinical point of view, although right now I know it's difficult for the non-for-profit organizations, but also to gain visibility of the problems and the impact that epilepsy has. So I don't want to belabor this. This is probably more from a clinical point of view, but I think for the individual watching today, I think it's important to know that from a surgery point of view, there's two kinds of individuals when it comes to epilepsy surgery. Those in which we can find an area to remove a portion of their brain to help stop the seizures. This is called resective surgery. I'll use that word throughout. And then the other forms of surgery we use are non-resective surgery. We know right now nothing works better than resective surgery. So if we can find a spot in your brain where a seizure are arising from, then the outcomes for you would be much higher in a scenario where we cannot find that specific spot. So this is the best data that we have. This actually comes from our colleagues out in London, Ontario. This was a randomized controlled trial published in the New England Journal of Medicine way back when now, but this data is solid and it guides what we do clinically. The bottom line is that for an individual who has temporal lobe epilepsy, the chance of being seizure-free after an operation is about 70%, and you can compare that to less than a 5% chance of being seizure-free on continued medication. So really no comparison between surgery versus medication if you're deemed to be a good surgical candidate. Being seizure-free, of course, I don't have to tell people who have epilepsy, being seizure-free is accompanied by a number of benefits, of course, and they're listed here. I think it's important to note in the context of epilepsy surgery is that we really would like to identify individuals early. We have a lot of data, which I have actually not listed here, that shows that the earlier that we're actually able to help with the epilepsy from a surgical point of view, the more likely you are to benefit from it, which means you're more likely to be able to reduce your medications and you're more likely to remain seizure-free after the operation. So that's one of our objectives too, is to sort of disseminate this information as widely as possible. And of course, why I very much enjoy being part of this, because it is important. As you know, knowledge is power, and so we need everybody to understand this when it comes to epilepsy. So it's all not always rosy, of course. So there are some side effects and sort of complications that can happen from epilepsy surgery. So there's always a possibility if we do surgery that you're not seizure-free from the operation. If we're operating on your memory side and your language side, then there is a possibility that you can have alterations in your memory. And as well, you can have some reduction if we operate on your language side in your ability to do things like naming things, proper nouns. Typically, however, these effects improve over about a year after the surgery, up to about a year or so, although it's likely that you do not get back to where you were prior to surgery. So I already talked about language. There's also a small possibility of losing a portion of your vision. I'm not sure if you can see my cursor right now. However, the black areas here on these figures show the kind of area that you might lose if you had if you were to lose vision. We don't call this a complication because we think this is really just a side effect that depends on your anatomy. Happens about 20% of the time. However, there is a small chance you could lose half your vision, occurs in less than about 1 in 1,000 cases. And in this case, you may also lose the function of the other side of your body for a period of time, but that would recover typically. And then there's a typical risk with any kind of procedure, things like infection, which occurs in about less than 1% of the case of surgery, and having a stroke of some fashion, again, less than 1%. Totally, I would say when I talk with somebody about surgery, totally some operations anywhere from 3 to 5%. We don't consider this, a low risk procedure. Very common procedure. Things to expect after surgery, so we we actually did a study, and one thing that actually come off the top that I sort of don't clearly see how painful it can be after the kind of because it's a surgery, so it can be actually quite painful. So put that out there. There's also been some swelling, which typically goes down in 2 to 3 weeks. Now, the temporal lobe is not the only area that we operate in, although it is the area if your seizure arising from there or an individual seizure arising from there, we do the best at. As soon as we move outside of the temporal lobe into other regions of the brain, we don't do as well. So if I were to say that, just remembering the numbers from the previous slides, that if your chance of being seizure-free after temporal lobe epilepsy surgery is approximately 75%, I would say that your chance of being seizure-free after surgery somewhere outside of the temporal lobe is around 50%. Now, a big part of actually getting to surgery in some individuals is actually finding out exactly where the seizures are arising from. And so we have a lot of tests that we do which don't require any type of operation. And for those of you who've been through it, you know that you have the MRI, for example, you're in the Epilepsy Monitoring Unit, you have neuropsychological testing. So these are all considered all non-invasive. We don't have to do anything, we don't have to implant anything. However, in situations where we can't figure it out, but we still think you're a good candidate, or things don't fit exactly, then we suggest or proceed with an operation which involves implanting electrodes. I kind of joke here that this aspect of surgery is kind of like real estate, is location, location, location. So we have to be exactly comfortable, or very comfortable, knowing exactly where the seizures come from to propose any type of surgery. And so this involves an operation to implant electrodes. The major risks of this procedure are very similar to the risk that when you have a temporal lobe epilepsy surgery, which is the risk of infection, which is under 1%, and a risk of stroke, which is under 1%. So location is very important. And so, in fact, at the Toronto Western Hospital, we've acquired new technology, which is the magnetoencephalography, which is another way of looking at brain activity. And I mention this because it's really been helping us in refining our plan of where we're going to put electrodes to figure out where the seizures are arising from. And so it measures these tiny little electrical fields. It's kind of like a very fancy EEG. It measures different things than EEG, but it also measures things from all over the brain, which a typical scalp recording doesn't. And this is headed up by Dr. Richard Wenberg at the Toronto Western Hospital, who leads up the neurophysiology lab. And it's also a powerful research tool. So this actually guides us in regards to our surgery. So this is the old way. We used to implant strips and grids. We actually don't do this anymore. It's a very invasive procedure. We've actually moved to stereotactic EEG, which is implantation of these fine wires into the brain. We actually now have started doing it with a robot. We actually did our first case just before COVID struck, and it's a wonderful technology, really refines what we can do. This is done in collaboration with Dr. Sunil Kalia, who's a colleague of mine who does deep brain stimulation surgery. This is us here on our first case. So we can leave these electrodes up to about 4 weeks or so. Actually, remove electrodes a lot easier than prior when we're implanting grids, where we can remove them under local anesthetic and typically go home the same day or the next day. An important thing to note is we're always trying to understand more about the brain, as Cynthia kind of alluded to at the beginning. And so we'd often will approach you to be part of our research study. And of course, this is voluntary, but we greatly appreciate those individuals who do help us with this knowledge-seeking endeavor. Now, what's your chance of actually being offered an epilepsy operation after your electrodes have been implanted? So it's about 65%, which is very good. These are the numbers out of the Toronto Western Hospital. And so our ability to offer you a resective procedure is about 65% after electrodes implantation. And then if you're not a candidate for that, then typically you would be a candidate for neuromodulation, which I'll talk about briefly. And then your chance of being seizure-free from your procedure, as I mentioned already, is anywhere from 50 to 75%, depending on where your seizures arise from. So if you're not a candidate for resective surgery, then we offer the vagus nerve stimulator, and many of you, if not all of you, know about this. I won't belabor this point, but the cool thing is that we have a really great relationship with LivaNova, and we always have the latest device to be implanted. So it's a really great, healthy working relationship we have there. There are, of course, side effects with vagus nerve stimulation. And about 20% of people will have side effects, which increasingly now can be reduced because the devices are very programmable. There's many parameters that we can sort of play with to reduce the side effects of the vagus nerve stimulator to maximize on its benefit to you while minimizing the side effects. We've also actually just acquired laser interstitial thermal therapy for doing basically minimally invasive surgery, where we can actually remove or resect, if you want to call it that, not really resect, but really coagulate or burn areas safely in order to help with epilepsy. These techniques are largely for deep lesions, which we can't access surgically. This is led by Sunil Kalia, and in fact, the device also has indications for tumor surgery. And as another colleague of mine, Dr. Paul Congham, who's an oncology surgeon, and so we're starting to use this device for both conditions. I want to switch a bit to some of sort of the research that we're doing. I think many of you, if you've seen some of my talks, know about Crania, which is Center for Advancing Neurotechnological Innovation and Application. And within this center, we're trying to advance new technologies to help people with epilepsy, as well as people with functional disorders like Parkinson's disease and age-related cognitive decline. So this is a large CFI grant that we were awarded. And I just want to mention one thing, which is starting to look like we're going to be able to realize this, which is something that is very near and dear to our heart, which is the cranial neuromodulation suite. This is actually going to be a dedicated operating room within the Toronto Western Hospital, specifically for epilepsy surgery and deep brain stimulation surgery. It's really to advance our ability to target electrodes to correct areas. There's a new magnet that's coming. There's a new MRI technology which will live in the room. There's a new electrophysiology technology. You've already seen the robot, which will be there, as well as this new navigation system. And the research that we'll do is to actually improve our ability to target specific brain regions towards improving outcomes for people with epilepsy and people with other functional disorders. The last thing I just want to touch upon, I don't want to make this longer than half an hour, is the other research that we're doing. And I think really the main take-home message is that we have a large team of people who are approaching the problem of improving the kind of technologies that we want to deploy to help people with epilepsy and other neurological conditions. We also want to understand the brain. It's a very important aspect of the work that we do, because how can you sort of affect any benefit if you don't understand the system that you're working with? And so we approach this from all sorts of directions, from mathematical and computational ways, experimental, clinical validation aspects, as well as very detailed electrical engineering approaches. This is the responsive neurostimulator device. This is a neuromodulation device, which is not available in Canada, and we're very, very motivated to actually build our own and commercialize this. And so this is to make this kind of device available, something better, of course, in Canada, as Canadians don't have access to this device. This is too much detail, but I just want to highlight the amazing work of Gerard O'Leary. He's a PhD student in my lab, and my collaborator, Roman Genov. And these are kind of the devices that exist right now. And this is kind of our versions of this, but really very much upgraded in regard to what these devices can do. And so now we're moving towards trying to develop, in fact, commercial devices to make them available for therapy. The last thing I want to talk about is that, of course, epilepsy surgery is not a panacea. It's not the only thing. It's very important to highlight, other things that we're doing in the context of epilepsy to help people manage. Of course, if you're not a resective candidate or you're not seizure free from our procedures, there's still things that can help with reducing seizures, reducing the burden of seizures, of course. And so we have a very multidisciplinary team at the Toronto Western Hospital. I want to mention one approach that we've taken is research into using music. And I know some of you has probably heard this talk, the wonderful talk that Marjan gave also recently at the annual general meeting at Epilepsy Toronto. Actually, she's now been able to finally publish her papers. It was a lot of effort. It was a long study, very detailed study. And so we'll be talking more about this in the coming, in the near future. So I look forward to that. And Marjan will have also things to say about that. And lastly, we have all sorts of other approaches to epilepsy, of course, and you may hear from others on this series. We have a genetics epilepsy program. It's very important, of course, because it's important that we understand the kind of epilepsy to actually not subject somebody to unnecessary surgery. For example, Dr. Berkovici heads up the ketogenic diet clinic. It's a wonderful addition. He works out of Southern Ontario, works very closely with Cynthia's developed Southern Ontario Epilepsy Clinic, which is really great. And Esther Bowie has a specific interest in helping women with epilepsy and runs a dedicated Women with Epilepsy program. And of course, last but not least, our efforts in the context of community outreach. And so I definitely applaud Cynthia and all her efforts. It's a difficult time right now for fundraising. So for those who have means, I strongly suggest, although it's difficult times, I understand, is to donate. Organizations like Cynthia survive on donations. I'm also very proud of my lab. We're very active in the community, which has been something that has been very, very rewarding for me. And so I always love these types of opportunities. So I just thank again, Trevor and Cynthia, of course, for inviting me, and happy now to take some questions.
Okay, we do have a list of questions here. Sure, thank you. I mean, talk about a mosaic of opportunities. This new technology, I mean, it's new. I've learned today of more techniques available, and how this does provide so much hope, and things are less invasive than ever before. So it's really great. This is a question. This is it's a hard one, but is after surgery, one is seizure free, is this permanent?
Yeah, so I think that's a great question. And, you know, I don't ever use the word cure because I think that's a very strong word. I think that once you've had epilepsy, that you are going to be in general more predisposed to having epilepsy later in life. And even if we do an operation, the operation, we know we have such good data, of course, that shows that, you know, for many people, this can be long lasting. But, you know, the very act of operating also causes some injury to the brain itself and some scarring. And so, you know, in that context, I would never say that, you know, surgery is curative. However, Trevor, are we okay? I think Cynthia cut out just for a little bit there.
Sorry, I did, yes.
Okay. You know, we'd never say it's curative, but in that context, it's a great question because we know that you have long-term data now that shows that you have a slightly higher chance than the average individual of having epilepsy, even if you had epilepsy surgery. We do recommend now that individuals stay on some amount of medication to sort of reduce the chance even further that they'll have a seizure. And so, you know, in the past, we used to think, you know, surgery was, oh, the goal of surgery is to sort of get you off medication and everything like that. And it's like, that's not our goal. Actually, our goal really is to keep you seizure free. And so, you know, in addition then to surgery are, you know, small amounts of medication. And I can give you an example. So if somebody's actually on 3 medications prior to a temporal lobe epilepsy operation, if they remain seizure free for a year or so, we'll actually start to reduce those medications. The average individual can reduce their medications by about 2/3. So you can go from 3 medications down to 1 and typically a lower dose, which has huge benefits, of course. I mean, those of you who are on medications know better than I of all the side effects that medications have. And then also important to note is that, you know, surgery is not a panacea. And so all the various things you can do to reduce your chance of seizures, all those healthy sort of lifestyle things and habits that are recommended certainly, those are things that you continue to do after your surgery.
I have a VNS question, a couple actually. Does VNS help with headaches, particularly migraines?
I mean, I think this type of data is a bit anecdotal. It may work for somebody, it doesn't work for somebody. Sometimes they do an operation and some people have had migraines, the headaches go away. Sometimes when they do an operation and people have never had migraines, they get migraines. These are very, very difficult things. So its primary indication is not, in fact, for headaches. There's no solid data behind that. Of course, the vagus nerve is an interesting nerve. They're starting to come out some data in regards to its effects on inflammation and the immune system. So I'm not that person who say never say never. It's impossible. I can't do that. I think we just don't understand enough about the things that we do. But if I would be hard pressed if you were in my clinic to say, hey, it's going to help you with your headaches as well. I wouldn't say that in the clinic.
It would, if it happens, it would be a bonus.
Exactly. That's right. Totally. Exactly.
Another VNS question. Does it work for both focal and generalized seizures?
Yeah, so I think that's a great question. So its primary indication is really for people who have focal epilepsy who can't have a resective procedure, but really it's a device that's used for anybody who's poorly controlled on medications. And one example on the focal side would be somebody, say, for example, you have temporal lobe epilepsy. However, we do the electrical recordings. We actually show that the seizure arising from both temporal lobes, and so we can't offer an operation because, of course, seizure arising from both sides. Something like that would be a very good candidate for vagus nerve stimulation. In that context as well, we've actually started to we'll start to further offer a form of deep brain stimulation. Now, again, in collaboration with Dr. Kalia, for the anterior nucleus. There's actually some good data now that shows 5-year data that actually shows that deep brain stimulation for epilepsy, particularly when it comes to temporal lobe type of epilepsy, may actually be as good as vagus nerve stimulator. In fact, there may be some benefit to both if some people are not very well controlled with the vagus nerve stimulator. In the context of generalized epilepsy, that's a very interesting question. So yes, it is indicated. One example, although maybe not perfectly correct to characterize this form of epilepsy generalized, which is drop attacks. So drop attacks or atonic seizures are actually a good indication for vagus nerve stimulator, as the vagus nerve stimulator has shown some particular benefit in that. Of course, if that doesn't work, then we also talk about the possibility of doing a corpus callosotomy, which is a form of surgery, which is a disconnection. So you're disconnecting the two halves of the brain. So yes, so it is really for individuals who can't undergo a resective procedure but continue to have epilepsy on medication.
More VNS questions.
Okay.
What is the difference between VNS and DBS?
Yeah, so vagus nerve stimulation surgery is not brain surgery. So it in fact involves placing an electrode on the vagus nerve, which is actually just in your neck. We do it on the left-hand side because the right vagus nerve actually runs your heart. And so we implant on the left. The left one is thought to sort of run your gut and stuff all your abdominal contents. And so it's actually not brain surgery, but it works by modulating the brain because the information, as you know, through nerves runs both ways. It runs from the brain out to the to the body, and then also information comes from the body into the brain via the nerves. And so the vagus nerve stimulator exploits that by sending signals back up through the nerve into the brain. And there's a lot of good studies, both basic science as well as clinical, that shows by some mechanism, which is people don't know exactly, but there's good data behind it, alters the threshold or the sensitivity of the brain to abnormal activity. And so, and in the pediatric population is also suggested or argued that there may be some benefit from a cognitive point of view as well, that children, particularly if they're developmentally delayed, may benefit from a cognitive point of view. So it really has this flavor of modulation, right? So it's really modulating the brain kind of gently over time. And that modulation, you can kind of really get a feel for it, because we know that the effects of vagus nerve stimulator are not immediate, that oftentimes it takes actually many months to years. And in fact, when we quote the outcomes from vagus nerve stimulator, we say, 70% of patients have the 50% or greater reduction in their seizures. That's actually measured at about 4 years out from implantation. And so it really has this modulation kind of effect. And then deep brain stimulation is exactly what it sounds like. It's actually placing electrodes within the brain. That's actually what I just mentioned, which was anterior nucleus of the thalamus, which is a target, which is a deep part of the brain where electrodes are placed. It's interesting because it's an area of the brain that's also connected to the temporal lobe, so probably why maybe it has some particular benefit in people who have epilepsy arising from the temporal lobes. So the risks are quite different for the procedures then. So one is brain surgery, one's not. And so anytime you do brain surgery, there's risk of stroke and hemorrhage and infection. Infection is also a risk with vagus nerve stimulator. And so, one of the primary mottos in medicine is do no harm. So, we tend to want to do things that are less invasive, of course. So first medications, try medications, then we do investigation, then maybe surgery, and then of course, what kind of surgery. So we always work from least invasive to most invasive. So yeah,
right.
Difference.
And there seems to be more least invasive procedures now. There seem to be more and more that are minimal invasive.
Exactly. So I think, the stereotactic EEG, and I think a lot of people know it as SEEG, because I know everybody sort of calls it by that, it's interesting because it was sort of one of the mainstays in Europe and not of much not applied a lot in North America. Now it's has made a resurgence in North America. And the robotic technologies help a lot in reducing the time of surgery, probably slightly improves or reduces the risk of surgery, just because sometimes these surgeries can take a long time to implant many electrodes if one's implanting a lot of electrodes. And we also feel that there may be some advantages from actually targeting things in a better way, but we still have to look at that. And that's kind of what that neuromodulation suite is all about. And we're very excited to get that up and running too. So I think it's always about, non-invasive approaches. We probably think though that, for the time being, the LIT example, for another example, is the laser interstitial thermal therapy is a sort of an approach, which is a great tool because, when we can't access things surgically, then we now have a new tool which we can offer, actually removing a part of the brain, but, with this tiny, fine little catheter. So, and I think this is all really technology driven. So it's a very exciting area. It's
pretty amazing.
Yeah.
Do you think Canada will ever get RNS?
But it's not going to get an RNS. It's going to get a device that we're going to build, and it's going to be better than the RNS.
Maybe you want to explain what that is too, the RNS.
Sure. So RNS stands for responsive neurostimulation. It's a device that's made by a company called NeuroPace. And RNS, its claim is, and I think it's an important claim because it's kind of where the whole field is moving, is that instead of just stimulating the brain constantly, and that's kind of what various types of deep brain stimulation devices do, is they just basically constantly stimulate the brain with the hope that it'll reduce the chance of having a seizure. And also we know that constant stimulation has very significant benefits in people, for example, in Parkinson's disease when they have deep brain stimulation. So it definitely works, and we call that open loop, which means it doesn't sense the brain, it doesn't know what the brain is doing, but it just keeps stimulating the brain. Closed loop, or this responsive neurostimulation, is where the device actually senses brain activity. It's kind of aware of what the brain is doing. And only when the brain is about to slip into an abnormal state, in fact, does actually stimulate the brain to prevent it from going into that bad state. And I use the word state and not seizure because these devices are also being conceptualized for other conditions like Parkinson's disease, for example, and other neurological conditions. So it's a general problem. And so these responsive devices are smarter, if you want to call them that, where they can actually sense exactly what's happening in the brain at every moment in time. and stimulate only when you need it. We think that, the RNS is, was kind of set the sort of a pathway for these ideas, but we think that we can certainly do better. And I think it's something too which provides us, the ability to understand more about the brain and provide better therapeutic options for individuals. So our vision or our goal is really in 5 years or so is to really try to push this our technologies. And so that Canadians can have access to these types of devices. We've had a number of conversations with NeuroPace, and it's a bit of a smaller company, and so it's quite expensive to try to get a device Health Canada approved, and they're currently not motivated to do that in Canada. So then that's why right now Canadians don't have access to that device. The other form of responsive neurostimulation, just to be complete, because we're being very didactic today, is that the vagus nerve stimulator, in fact, is also closed loop in that it senses the heart rate activity, and it can be used to, and heart rate can be used to sort of inform as a proxy in a way that a seizure is happening or may happen. And so these types of algorithms, these computational techniques, actually are showing great promise, in that some patients do have very clear-cut changes in heart rate that are associated with the beginning of their seizure, and the device can actually sense that and then provide additional stimulation. So that's the second of the closed-loop devices, or the responsive devices available on the market.
Wow. Okay. We have a lot of ENS questions. This is an interesting one. Speaking of technology, how can a robot safely do brain surgery?
The robot doesn't do the brain surgery. The robot is, of course, under our guidance. What the robot does, though, is that, and it may be a little bit hard to describe, is that, as you can imagine, we have to place an electrode into a specific spot in the brain. So you need some kind of map or a coordinate system. And we have that. We've done it for decades with a frame. So we place a frame on the head, and that becomes like a map for us, and then we use that map to guide the electrodes. Moving the frame to different regions or different targets is not a trivial thing, because there's actually 5 coordinates that you have to actually manipulate. So for every single electrode we place, we have to change the frame in 5 different ways. And so the good thing about robots, and different than humans, is humans actually do make mistakes, right? So even though we have double check and triple check and that amount of checks, these errors can still get in there. The beauty about the robot is that it's so designed that it doesn't do the surgery itself. What it does is that it positions us in the right direction so that we can actually implant the electrode. So it's really a new guidance system, which is basically controlled or driven by us. And it removes all that kind of fiddling that we would call it, where we have to keep changing the frame, and we have to do this physically. Like we have to undo screws and bolts, and then loosen things, and then move things around, and we have to do that in 5 different ways with this frame. So it not only reduces the length of surgery, but it certainly makes that component easier. And we can then focus on other aspects of safety, and also focus more on the planning rather than the actual physical aspects of doing the surgery. So it's really a very interesting technology.
Wow.
Yeah.
Somebody's asking, you've mentioned stroke several times. My epilepsy is a result of a stroke. Would that reduce my chance of being a candidate for surgery?
No, not necessarily. I mean, post-stroke epilepsy is uncommon, but the one thing about a stroke is that it tends to be focal, so it follows a very specific anatomical location. And so we have certainly done surgery for individuals with stroke. Stroke itself, as you've very rightly pointed out, can cause epilepsy itself. And so that does not exclude an individual from being a candidate. We'd go through the typical workup to see if one is a good surgical candidate with all the tests, and that would be the kind of the final. We'd all use all those tests to determine that. So nobody's excluded up front because they've had a stroke that causes their epilepsy.
Okay. A pandemic aside, what is a typical time frame for an individual for respective surgery, from preliminary testing to surgery completion. So I'm guessing from the EMU to the
Right.
actual surgery. I'll ask that part of the question first.
Sure. So yeah, so basically, once you're in the EMU, after the EMU, we have basically all your information. We have the MRI, the neuropsychology, and the electrophysiology. And then we review things collectively as a group. And then if you're a surgical candidate, you're referred to me, and then I book your surgery. If you're that very clear-cut and straightforward type of individual who does not require any further tests, I would say that the time from being in the EMU to the time of surgery is somewhere between 3 to 6 months. We do have issues in regards to our processes, and that's something we're trying to work on, that to reduce the time it takes to go to resective surgery. On the other hand, if you need an invasive procedure, it can take much longer, and that's because we do have somewhat of a wait list for this, just because we can only do so many surgeries per month, because we have only so much information and data that we can process in a month's time. So we typically only do about 3 to 4 electrode implantations per month, and so it can take close to sometimes a year to a year and a half to actually come to that procedure. And then once the electrodes are implanted, you're about in the AMU for about a month or so, and then we would have to review all your information, and then maybe as well another maybe 2 to 3 months to get to your resective surgery. So it's a long haul. However, once you're discussed at epilepsy rounds and you're deemed a surgical candidate, then the chance of the time it takes to actually go to the resective procedure is actually pretty fast, because my practice is I only do epilepsy surgery, and I do some spine surgery, and we prioritize the epilepsy surgeries. So the epilepsy surgery always takes a priority for me in my clinic.
Oh, that's good. That's right in line with a lot of our experiences that we've had. And then likewise, how long will a patient wait for surgery when VNS is the treatment of choice?
So again, if you come to my clinic and we have a solid plan for you, whether it's VNS or resective procedure, it's typically not very long. So it's probably, if you see me in clinic, it's probably because your date's coming up, and you'll probably have surgery within a month or to 6 weeks. I think that the time though that you'll be waiting for is actually to see me, because that's kind of the time that you end up waiting. And again, we're trying to communicate that more to individuals, that can be variable. But from the time the EMU, the time that you're discussed in clinic, the time you see me is probably 2 to 4 weeks, and the time of surgery is about 2 to 4 weeks as well. So I'd say 6 to 8 weeks would be total time if you have VNS or a resective procedure from the time that you're discussed at epilepsy rounds.
Okay, that's pretty good.
It's good. I mean, from the resective point of view, yes, it's unfortunately not good if you need intracranial recordings. It can be a very, very long wait. And although it sounds good, then of course there are gaps in our processes. So sometimes, people are like, well, I haven't heard anything from, and it's true. And it's not that they haven't heard anything, they haven't heard anything from us. And so it can be longer for some individuals. And, the other thing is we don't have good processes to keep, people are very complex, then they end up having multiple tests. And so then, you have like a PET, and you have to come back and be discussed. And then you might have a MEG, and then so these things can add significant time to the whole process.
Waiting for appointments.
Yeah.
Can you please expand on the RNS statistic of seizure freedom being 0%?
Sure. So in fact, it's actually pretty easy. You only have to remember like one number for all the neuromodulation. Believe it or not, I mean, it's kind of crazy. So we've reviewed all this. So in this literature, when it comes to neuromodulation, there's sort of a category which is called responders. And so responders are considered people who have had a 50% or greater reduction in their seizures. So that's called a responder. And that's the same kind of number that's used for all of the neuromodulation. So it's VNS, RNS, and DBS, anterior nucleus of the thalamus. And surprisingly, it turns out, is that for every single one of these devices, about 70% of people who get these devices are responders. So it doesn't matter what you look at. If it's VNS, it's 70% of people are responders. If you look at RNS, it's 70% of people are responders. And if you look at DBS, it's 70% of people are responders. So it's actually quite easy to remember the number. The hard part is that the devices may not work for one individual, and so the other device might, or they might be complementary. And this kind of sort of emerging field of actually combining these devices together. But that number, that super low number, was not so much about responders. It's about the individuals who are actually seizure-free. So none of these devices right now, for example, RNS or VNS per se, argue or are really used or are argued to make you seizure-free. And that's something we want to work on. So we think that we can improve the idea of a responsive neurostimulator or a closed-loop device so that it works better, makes more people seizure-free. And that's kind of what we're working on. So it's not to put these devices down. Of course, epilepsy and neuromodulation is a very difficult problem. Epilepsy is a very complex problem of the brain, so it's not an easy problem. So it's not to put any of these devices down. I think people are really trying to help here. It's just that we know that there are limitations, and so that very low number was about the number of people who are seizure-free with these devices.
I think this is part of the same question or follow-up. How do you see this improving? I understand the concept of less invasive to more invasive. However, when the medication has dozens of side effects, many of which disable normal life activities such as walking, working, driving, thinking clearly, does the risk-benefit analysis change?
Yeah, so I'm totally on board with that question. I think we are in a positive way very aggressive about surgery. So we really try to figure out whether or not somebody can benefit from an operation. So we'll do whatever we can to sort of figure that out for the individual. I completely agree, and that's in why we're also very motivated, because we know there are benefits from in all those domains that the individual listed. If you're able to sort of reduce your medications. Really our guidelines in Ontario are that, if you have seizures on two medications, two first-line medications, tried in succession, then you're medically refractory and you should have a surgical workup. That's really the guidelines, and you find them on the internet, and they're all over the place now. So if you have, if you're a practitioner or your family doctor argues with that, you can direct them, to the Ontario guidelines, because those are the guidelines now. So it's hard and fast now. There's no like, maybe we'll try 3 or try 4, or let's wait another year. It's literally, if you've tried 2 first-line medications, you've tried them at the correct doses, and you're continuing to have seizures, then yes, I agree with you 100%. We want to see if we can help you with epilepsy surgery. And we do know for individuals that risk-benefit ratio is in the individual's favor if we can find an area that we can remove with surgery. So yeah, totally on board.
We find that with our agency being community support, we do have clients who would fit this description, and there are, as you know, some neurologists and even epileptologists who are adverse to surgery and don't want to send their patients on to this. And I know I've found that we will advocate on that same vein. We will say, go to the website, here are the new guidelines for epilepsy care in Ontario, and you've failed 2 drugs, so you are entitled to have this workup. And so Absolutely. We have them self-advocate.
Absolutely. And it's like, the physician's role here is not to be a gatekeeper, right? The physician's role is to facilitate the process that an individual can gain information and knowledge about their condition. I mean, that's really should be our role as clinicians. So, for somebody to say that surgery is the last resort, that's not correct, in fact. In fact, epilepsy is very different than other chronic conditions. So, let's compare epilepsy to a chronic condition like arthritis, for example. In that situation, an individual who needs a knee replacement, you will want to wait until that individual is disabled by that condition. So you will want to wait longer so that when they need their surgery, that they'll benefit from that. The difference between epilepsy is that we can figure out very quickly that somebody is not going to benefit from the medications. It typically will take only about a year or 2 to find out if somebody is medically refractory. And so why would you want somebody to wait 20 years for something like that? Unnecessarily. And this is what we really see. This is really the struggle, which is that it's not a typical chronic condition. And I think from a consent point of view or an individual autonomy point of view, I think nobody really has the right to say, well, you'd never want this. Actually, really what it is about you getting information. And of course, some people will not want it. Not everybody wants to have surgery, and that's totally their prerogative. But it's that you have the knowledge and power. And I think that that speaks to kind of the work that you do, Cynthia, is what these organizations do, is that, it's empowering individuals. That's really what our goal is, right? And then it's up to the individual to make their decision when they're given all that information. And I think that's really, it's not fair to remove somebody's autonomy by becoming a gatekeeper. And so, if there's, so I'm sure you struggle with that. I'm sure it's not,
well, we do.
as well.
It bothers me a lot because we experienced that in our own family, and for years the epileptologist would refuse to refer, and so out of desperation we did our own advocacy, and we're seizure free and we're off living our life. And it's as anyone knows and has attested to being in your OR, when you're seizure free, it's life changing. You get your life back, is what people often say. And so, as you said, the patients should be given the respect and the ability to I guess address their own care, their own path.
And the same thing applies to everything. So, let's take, for example, the music sort of therapy that, the Mozart stuff or the ketogenic diet. These are all things that people choose to do, right? And you can choose to be a participant in your own healthcare. This is this whole idea of self-efficacy and self-management. And, oftentimes what medicine or medical practitioners do is they take that responsibility from the individual. I'm very much about actually giving a lot of responsibility back, because it's like, it's you and it's yours. And I'm here to help. And so, and I think that sort of disempowerment, it just makes it worse, because then as an individual, and others can speak much better to it than I can, then you feel helpless with your condition. However, we know that epilepsy too, as well, is affected by, how much you sleep and your stress levels, and external environmental things, and all sorts of things. And we know that by modifying these types of things, it can help. Maybe it won't be 100%, but all these little things can help. And so, and epilepsy surgery is a part of that. It's just a part of that, and I learned that. The surgery I do for that one individual, or the time they spend in the hospital, is just a fraction of the time that individuals spend in the community and their families. And so all these things contribute, right? So it's not one or the other, it's everything together, right? So.
That's right. Whether it's VNS or the diet or surgery itself, the goal is zero surgery or seizures. That's the goal. Exactly. I tell people. That's exactly. The goal. Yeah.
And if you can't achieve that, to manage as well as you can, to derive the greatest benefit you can from life, given that you might still have have epilepsy, and that too is a very important thing, which are the kind of services that you provide as well, right? So it's really a very, very holistic thing. It's not one or the other, for sure. I totally agree with you.
Right, it's the comprehensive care. So the social workers, it's because of the comorbidities with the mental health as well. So a question here, it's what is an aura considered an actual seizure?
So yes, so in fact, an aura is thought to be a small seizure in an area of the brain that doesn't really spread far enough to affect an individual's consciousness. So the reason why somebody can remember their aura is because they're actually conscious. And so an example is temporal lobe, where an individual will describe deja vu type of phenomenon, or that feeling in their stomach, the rising feeling, or the lump in their throat. These are all considered to be abnormal, or these are all sort of things people feel because there is abnormal activity occurring within the brain. So auras do provide some information in regards to where the seizures might be coming from. And you can see this with many pathological. You can see that these are small seizures that are occurring that people might not. That sometimes, in fact, people don't even have aura with these small seizures, so we can actually be sort of unaware. So I would call it as sort of a small seizure.
I had a little bit of trouble with our connection there, but the short answer is yes, right?
Yes.
And I don't know how many children you've had in your OR, but there's the question: what age for children are children considered for epilepsy surgery?
So children do spectacularly well. So in the pediatric age group, there is just a whole, ton of literature that demonstrates the efficacy of epilepsy surgery. Whether it's the resective type of procedure, the implantation procedure, the vagus nerve stimulation, the deep brain stimulation, and the children have a benefit, over people who are older, which is they have the plasticity of that young brain, and so they can recover from things which older people can't. So one example is individuals who have seizures coming from one half of their brain, and they undergo a hemispherotomy, for example. These individuals can return to physical activities. They can go to school, go to university. Epilepsy surgery in the pediatric age group is very, very effective. In fact, we can see that in young children who have epilepsy, when their seizures do abate, through medication or treatment, that they can regain their milestones and sort of return to sort of previous levels of cognitive activity. The epilepsy surgery in the pediatric population tends to be different than in the adult population. In the pediatric population, it tends to be more around sort of developmental abnormalities or sort of structures of the brain that are not formed properly. And so often the surgeries tend to be more extensive than the kind of surgeries that we do in the adult population. But there's really incredible literature. There's an entire network for pediatric epilepsy surgery through the province, through Canada, and they've demonstrated just amazing outcomes in children. And I think they do surgeries, can do surgeries at a very, very young age. It's kind of crazy. But so, and, there's really great people at SickKids. So there's a new staff, George Ibrahim has just started there as a fantastic surgeon and scientist, and Dr. Rutka and James Drake at SickKids. And of course, in London, they have a pediatric program as well. So,
from a parent perspective, I know with a child, the parents make that decision for them. Once your child becomes an adult, then they make that decision for themselves. And it is definitely a different perspective from a parent perspective.
I can only imagine.
That's right. I have a lot of VNS questions, but I think we're ready to wrap up here. Okay. It's almost been an hour. I thank you so very much,
my pleasure.
Dr. Valiante. It's been I can't get over the technology just everything is coming along so quickly and fast and furiously, and so the knowledge is power. That's what you have to take away from this. You don't have to make a decision until it is a decision to make. Absolutely, with regards to that surgery, so find out. But I want to say on May 14th we have Dr. Elizabeth Donner, so you can have your sick kids and children questions as well. Her topic is SUDEP, so that's the elephant in the room in many cases, and so that's 3 p.m. on May 14th. And Dr. Valiante, it's just always a pleasure, and it's so nice to see you and have you with us. And the presentation was phenomenal. So thank you so much.
It's always a treat. So thank you very much for having me, and I look forward to when we can do this in person again.
That's right.
And that day will come. I'm very sure.
Will.
But, yeah. Okay. Take care, everybody.
Thanks so
Cynthia.
Much.
Thanks, Trevor.
Thank you.
And thanks everybody for joining.